Medical and electronic infrastructures will be bringing it to a new stage of providing health services. Medical and levels will be infrastructures bringing it to a new stage of providing these services. Will improve the efficiency of doctors and improve the process of diagnostics and treatment and the efficiency of the health system on the whole. This document has been developed with interaction with the WHO and takes into account the plans of the domestic system of health on the advice of WHO, funding from the world financial institutions and the state national programs will be taken into account. As we implement this concept, several key problems will have to be dealt with. We'll be having a comprehensive informatization of medical facilities. This will allow us to convert our medical documents into electronic format. We'll be introducing an integrated record. We will try to have a situation when the distance between the patient and the doctor will be removed in the course of the implementation of an eHealth system. Will have to deal with protection of information and confidentiality. Telemedicine will be contributing to distance consulting. This kind of interaction is now in place between the national and the regional hospitals. For example, the first and the second anti-TB dispensaries and all adult outpatient clinics have a system which is unique for Eastern Europe, which is an integrated system of fluorography examinations where dozens of electronic consultations are held through this system, and we expect important outcomes through the introduction of this system. It's important to identify them. It's swift and prompt decision making, reduction in expenses, conduct of screening activities. Furthermore, we want to improve the participation of our population in the and increase their responsibility for the protection of their own health. We think that this objective can be reached through direct access by the population to the current information on their own health and feedback with their doctors. Special attention is placed on the individual monitoring of the health status. Introduction of digital technologies is a revolution for patients and for doctors. Each citizen, each individual can have an access to their records, so the patient comes to be in the center of the health system. So we expect economic and social effects. We expect a decrease in mortality, improvement of the increasing of the lifespan, improvement in the service, medical service.
Perhaps the interesting part is the strategic definition of the 4 dimensions that are important on how they would achieve an integrated health portal with integrated health information. One aspect deals with participatory development, both engagement of all stakeholders and also co-development of solutions between public and private stakeholders. The second dimension focuses on common infrastructure and systems. All of this is linked and managed by a joint strategy and investments and solutions. And the fourth dimension has to do with developing and maintaining a culture of trust among all of the stakeholders involved and encouraging the will to change and the courage to adapt to the change. Now, the next country is Ireland, and this eHealth strategy, again, is expressed in a different way. It proposes 7 actions that would need to be implemented in order to implement the objectives of the strategy. What is interesting is that it focuses on outcomes and describes them on different stakeholder groups. It recognizes very much that governance is key in order to enable the implementation of the strategy, and it also recognizes that there is a great need to re-engineer and change work practices and processes. And if we look even further, I put into the next 2 slides the 5 action areas that are outlined in the Irish eHealth strategy. What I would point out here is that, again, here you can see in the point 2 that the strategy establishes a goal to strongly brand eHealth Ireland and all the activities underneath and advocate for its importance. You see here that the national priority projects emphasize the common national health identifier that allows for integration of the systems across the health information system and eHealth, e-prescription, online referrals and scheduling, and telecare. With regards to the need for re-engineering of the processes, you'll see that the work streams in number 4 are very much touching on this. And what is also interesting is the 5th point, which is that the strategy requires that each government department and agency that have a role in either generating or using eHealth solutions must develop strategies to or an action plan that will define how they will do so. Now, the 3rd country is Kyrgyzstan, and here the eHealth strategy is again expressed in a completely different way. Kyrgyzstan used the WHO and United Nations International Telecommunications Union's National eHealth Strategy Toolkit to express its strategy and action plan for implementation of eHealth in the country. And it starts with a very pragmatic statement of vision. Its main focus is on achieving and delivering an integrated health information system for the country. And the last country is Finland. And Finland, again, has a different way of expressing the eHealth strategy. And what is interesting is that the eHealth strategy is very much connected to what they call e-social strategy. But what is interesting is that the strategy also addresses international aspects of integrating the services across the borders of Finland, not just the national focus. It very much focuses on enabling and empowering individuals accessing and using information for what they need. So citizens need it for their own information and as service users, the healthcare professionals. The strategy refers to use of information and knowledge, and very big emphasis is given to steering and cooperation governance in information management. And Claudia mentioned before that actually Finland isn't even stopped there. They had actually integrated fully information from various sectors, and health information doesn't stand alone in silos. It is actually integrated across sectors and used for policy. So I will stop here. Perhaps just several points from just looking at the eHealth strategies. I would summarize by saying that while eHealth solutions are patient-centered, they must also contribute to public health and to the needs of policymakers. The 3rd point is not new to any informatician. The usefulness of any solution can be ensured only by involving the actual users of the system. And if we now expand this idea to the health information system in general, of course, by involving all stakeholders, not only patients and healthcare professionals, but also public health professionals and the policymakers, this will ensure that there is bigger uptake and more support for the health information system and eHealth as a whole. And of course, seamless exchange of information across the systems will allow that information will be used across sectors when relevant by all of the parts of the society and across all of the levels of the health sector. Now, thank you very much. I hope that this will spark some discussion, and here is my email address if you would like to discuss with me or share with me any of your experience. And I wish you a successful conference. Thank you very much.
Спасибо большое.
Thanks a lot for your remarks. The next paper will be dealing with the experience in Estonia of creating national e-health system. We'll be hearing Peter Ross, consultant for electronic healthcare questions, World Bank. I request that you please stick to the time frame because we'll be all watching an opening ceremony for the exhibition. Dear Minister, dear Vice Minister, colleagues, my name is Peter Ross. I come from Estonia. I'm professor of eHealth at the Tallinn University of Technology. And in addition, I'm also a physician, a radiologist. I've been working at the Tallinn Central Hospital. I'll try to be quick, of course, and to provide you with some practical aspect and vision. I'll start with graph. Belarus and Estonia are almost neighbors, as you know. It's important for Estonia, as Claudia has just said, each citizen, each individual has a unique personal identification code. All services are provided using this code. The system of the health system, solidarity, insurance, and expenditures on health is only 6% of GDP. Private or state-owned or municipally owned facilities do exist in Belarus. So the primary level is general practitioners. If we are to speak about e-services, e-health services in Estonia, we are to speak in general about e-services in Estonia on the whole. Even fishing in Estonia cannot be done without an e-format, an e-permit for fishing. Now, about Estonian information medical health system. It's quite a unique system because this informatizes and automates all key aspects of this type of activities, registers information of the patient from birth to death, and this system is based on a reliable architecture. Nothing can be done overnight. We started planning back in the year 2000, and the funding came from the EU in 2005, and our system has been in place since 2008. Some facts of our history: in the 90s, we made use of only a few electronic services like electronic medical
records. Gradually, we introduced more such things. In 2001, we had a transition to electronic payment requests. At that time, hospitals and the family doctors were stopped using paper, and electronic medical records came into effect as there was a recommendation for the national system to integrate vendors, suppliers, and drugstores or chemists services gradually. This you can see in the architecture of our system. What is important, we have two aspects to be noted. One thing is a secure platform for data exchange. We call it X-Road. It's the central part of the system. The second important aspect is that all the data are stored where they are entered. That means that if I work at a hospital with my BIMIS, if I deal with difficult situation, a patient, then I send a request to the central system, and from there I can see what images or what photos were made by other hospitals, what inscripts were or copies were made for these particular patients. If the data are stored where they were entered, we can have different services in place. In the central system, we have the following documents accessible: critical data, then transcripts from visits by family doctors, digital images, e-counseling, emergency aid. There are a lot of services like this that we offer, that we provide. As of today, all medical facilities, all medical institutions are united in one system, integrated in one system, irrespective of whether they are private or state run. It is mandatory. It is about 35 million different medical documents, records, like outpatient clinics, docs, images, diagnostics, documents. A few words about MIS. It's not only documents, but also images, cardiograms, different tests, investigations, endoscopy, histology. It's not only records and documents. And the subject of these records is not only to make use of treatment documents, but also provision of data, financial reporting, also management of the economic aspects in the operation of a hospital, and also accounting for the personnel. So it's not purely medical data, but also financial and economic data. Now, a few words about the patient's portal. In Estonia, each and every individual has access to their records, and you can use your ID cards. Also, a mobile ID can be used. That means it's a secure way to access data. Security is very important for us. So there are a lot of different services that you can provide, like completion of health declaration, access to various documents and records. What's interesting, each person can observe data. It can be seen who and when observed this data. It's an important way to audit. That means that not a single data cannot have access to data without the patient himself or herself being aware of that. So this is how it looks like. It's done in 3 languages, in Estonian, English, and of course Russian language, because 1/3 of Estonians are Russian speakers. They, as I said, you can use either a mobile ID or an ID card. The slides move or change very slowly. I don't know what the problem is. You can see how it looks like. In the middle you have data on your health. If you can see if the person has insurance, who the family doctor is. Also, there are data on children under 19. As a father, I can see data on my younger child. What else can you see? What you can see also the bill, how much was paid from insurance, and there is a log book. The interesting thing about it is how much this central platform has been used, how extensively. In 2012, on the left, we just started, so the red columns indicate females, the blue one indicates male. I don't have to say that at first only young females made use of it. Of course, we know that all women are young, but in 2015, you can see more adults and males began to make use of that system. And for me, the best of the graphs is this one, combining 3 actually. The red one shows requests from the central system made by physicians. You see, in the first 2 years there were very few requests. As of today, almost 2 million requests per month is registered. And what is more important is to see this blue graph, and this shows requests of individuals from the patient's portal. You see, the first 3 years you can see nothing happened. However, as people saw that they have access to that, you see, last year we registered a situation when individuals made more requests than physicians. This is a very good indication of how important it is to give access to data for patients. And the green graph shows the number of the documents. Now about an e-prescription, it was also a success story. I know that in your case it is done quite successfully, and as of today we don't have paper prescriptions, almost no prescriptions, and this transition occurred within 1 year. No one wants to have prescriptions on paper, and actually they don't get them. The right graph shows expenses on paper prescription. You see a very sharp reduction in the number, in the amount. Now, what is our thinking? What are the main factors for our success story? The first most important step was that the management was very efficient, clear-cut. In my view, Belarus is following a very good centralized system. Then legal transparency. We changed 16 or 17 different instructions and other regulations. Our parliament wanted very much to change the system. They were very eager. Then it's a mature ecosystem for electronic services in Estonia, as I have just as I have said. It's a secure platform for data exchange, and it's provided by the state, by the government. All citizens, all entities, legal firms, they can make use of that. The methods for identification in online regime, or the ID cards or a mobile ID, a very good agreement on the rights of access under our laws and regulations. There is a clear-cut description of who and what data can be accessed and who can access them, what doctors, and for what reason. An important moment is standardization, not only standardization of medical data, but also standardization for data exchange. Now, problems. The problems are not unique ones. Doctors and other medical professionals must change the style of the language. Now everyone can see what is written. You cannot hide or conceal anything. Physicians, doctors, they are not quite happy that patients have access to the data, but this can be observed across the world. It's the same old story. Then security is a very important thing, and much attention in our case has been paid to this. However, the convenience for users has been underappreciated. Our doctors said that we want to provide treatment and not to have to play with inconvenient information systems. Also, we can see that patients are not interested in medical data. They are interested in services. Then the changes in the health system connected with digitalization are often overshadowing the expected use or benefit for medical physicians. Changing the mindset is very important. And in conclusion, we see that in the thinking of the medical personnel and staff, there occur a change in the paradigm. There is more structured data. We medical specialists, doctors, we are not owners of the data. There's formalization of the entered data, fewer assumptions, more data is used, not only purely medical, but health data and social data. There, Elena Leonidovna emphasized that it's very important that you have access to health status data, not only to disease data. And a change in the working environment. And there occur changes in daily processes and switch from linear process to space process. And what is important, it's important to say to the doctors, colleagues, make use of the central system. This is for the benefit, this is for your benefit, and you will be in a much better position to make an adequate diagnostics and provide better treatment. The same holds true for the citizens. You have the right, you are entitled to see, to have access to the data and to make a decision as to where to go for treatment and how to treat it. Thank you. Thank you, Petros. The next speaker is Tatiana Lapetskaya, who will be talking about the experience of the electronic healthcare platform implementation in China.
Good morning, dear ladies and gentlemen. My name is Tatiana Lapetskaya and I represent ZTA Corporation. The goal of my presentation is to brief you on implementation of eHealth in urban district in China, and that project was implemented by ZTA. Prior to proceeding directly to my presentation, let me tell you in short about the corporation, because as practice has shown, our company is mainly known as the producer of mobile phones, but actually it's only a small percentage of the total output of the company. So ZTA is a telecommunication Chinese company with more than 30 years experience. The corporation has taken lead position on market all around the world due to the fact that over 10% of companies' revenues are annually spent on R&D. As a result, for many years, the company has taken leading position at its market, and internationally, it has kept pace with the newest developments. One of the key areas, in addition to telecom equipment, has been development of intelligent system for the smart city. Consequently, the system of eHealth has been one of the systems, and about the experience of implementation of the system in the project, I will tell you in a couple of minutes. Now a few words about the prehistory of the project. It was initiated by the city government in 2014, and the main objective was as follows. There were several issues at that time in the sector. Firstly, poorly development network between the medical institutions and insufficient level of computerization and informatization. There was no proper exchange and interaction between public health institutions as well as the administrative authorities. The quality of capturing information was not satisfactory, as the quality of public health services was not sufficient. There was loose, poor access to medical information. As a result of project implementation, it was anticipated that through eHealth system, providing proper interaction and good exchange of information for all health institutions, all the aforesaid issues will be solved. And now a few words about the project as such. Based on the set tasks, ZTA designed and implemented the system. The system covers over 3 million people, and these 3 million are the entire population of the city. The system got connected to all public health institutions at all the levels and types, such as hospital, outpatient clinics of different levels and administrative subordinations, hospitals of traditional Chinese medicine, customized facilities for babies and mothers, bank of blood, emergency services, and of course rural clinics and the focal points of primary medical assistance. The main components of the systems are informational platform, public portal for medical services and medical applications, cabinets of primarily diagnostics, ID cards, and the system of management in public health. At this slide, you might see the structure of the solution. I won't be going into the details because, as you see, it contains a lot of technical elements, but let me tell you about the most important. Primarily, within the scope of project implementation, network infrastructure was established, which covered all health institutions. There was a specialized data center for storing and processing medical information. Key component of the system, which was implemented within the project and which is the core for any system of that kind, is electronic records. Many speakers have already mentioned that this is the tool providing registration and storage of all medical data for individuals, for patients, such as the history of examinations and visits, diagnostic results, perhaps even surgeries or laboratory tests, analysis, medical images, and so on. As we might see on the layout, the registration of data takes place at the level of institutions of public health. Also, in public health institutions, we've introduced laboratory informational systems, system of storage and transmission of images. An integral part of the system is the platform of information exchange. It provides exchange and transmission of information between the components of the system, and please pay attention, but within the project, the international protocols were duly acknowledged. At the scheme, you see the integration level, a sort of a data center storing all the information and where the processing takes place. In addition to that kind of information, which I have mentioned, that is EMRs, it stores the information about the health institutions and medical workers in the particular district, inquiries, and other kinds of information. Here we have the levels of applications, such as functional services of the platform, and I will tell you about them a little bit later. So, at this slide, you see informational medical platform of Tsinhuandao city, which highlights major services, and I will give the details on all of them. But now, please note that access to those services, to each of them, is available to the categories of users. For instance, public portal of services is designed for using by patients, by general public. Public health is designed for administrative users. And now I'll give you some details. Service under the name medical services, which means analytical services providing generating statistics and doing analytics based on the parameters such as the percentage of treated patients but who have approached within a month again. Statistics on diseases, total number of hospitalization, duration of hospitalization, and many other aspects. Thanks to such a service, there is a continuous monitoring of rendered services, and the result performance gets better. It also provides monitoring of statistics and analytics on medical costs. Consequently, they could be optimized. Such a service is not designed for being used by patients. Only administrators from medical institutions and administrative authorities have access to it. The second service is public health. It is designed for being used by administrative and customized users, providing monitoring over situation in public health at regional levels, not at the level of particular institutions, but at the higher level. Such a service is made of several softwares, such as system of control and managing over chronic diseases. The next service, which is accessible to administrations in public health and local authorities, is the module of control over pharmaceuticals and preparations, providing monitoring and control over their use and also replenishing timely the stocks of medical institutions. An integral part of this service is the functioning of the e-prescription. Another important component of the system, which has been implemented within the project, and incidentally that was mentioned by the colleague when telling you about Estonian situation, and he mentioned ID card in public health, and it means universal ID card for access and managing the data of the patient. In addition to identification and access to records, one can pay through it, which is most important for such a country as China, because they do have paid medicine, and also insurance information is embedded there. One of important elements of the platform is a public portal of medical services designed for being used by patients. Through a personal cabinet, a patient may have access to his or her medical information. He or she may review any laboratory tests, all outpatient statements, information on examinations, on e-prescriptions. There is an opportunity of booking statements and quotations. Another service in the platform is the system of routing for the patient. I mean movement of the patient between the doctors, the itinerary for the patient, if I may say so. When a therapeutician sends the patient to the specialist, and this can be done for different medical institutions. For instance, a patient from the outpatient clinic moves into the hospital or moves to the other outpatient clinic based on the residence, and still there is a comprehensive exchange of information about the patient. It is quite simple because this solution provides recording or booking your visit to the doctor using not only the individual cabinet but also the applications on smartphones. And the last element in the system within the platform were the cabinets of primary diagnostics. They were equipped by specialized equipment Within the scope of the project, a number of doctors have got the equipment, the so-called mobile terminals for primary diagnostics. You may familiarize yourselves with it at our stand, so have a look, and you may have even the chance of touching it to see how it operates. The main value of this terminal is that the examination could be done both at outpatient level and at the place of residence of the patient, at home of the patient, because the terminal is mobile, and it also provides, if there is no mobile communication or the opportunity of connecting to via internet, to get connected to the platform and input all the data into the EMR of the patient. For instance, the terminal provides installing and undertaking remote consultation and counseling with specialists. And if we mention the performance or the results of the system, I may say that, of course, it provided better capture of all the information and the use of all the data. As a result, the quality of medical assistance has improved. For instance, less time was spent for registration and retrieval of information, and for other procedures there was a lower risk of doctors' mistakes or errors. As stated, it cannot happen that a statement was lost or the entry was made in a most illegible form. And so all the prescriptions, all the assignments are recorded there. For instance, allergy particularities are specified there, and that mitigates risks of improper prescriptions, becomes lower. Financial costs have also dropped. If we consider them broadly, many processes have no longer been duplicated. It could not happen that some laboratory tests have been done several times in different institutions, and that also resulted in better performance. And of course, the opportunity of collecting data and the analysis in the real-time mode provide prompt reaction to any emergency situations and avoid the outbreaks of the diseases. Because of the introduction of the system, all layers of the population and doctors and the government have prompt access to medical information. As a result, there is good monitoring of public health in the real-time mode in general. Thank you. Thank you for your attention. Thank you for the most comprehensive information. Let us continue.
Now we'll be talking about the experience of Northern European countries, Nordic countries. We'll be listening to Dmitry Etin, eHealth Chief Architect of in Open Text Company from Austria. Good morning, colleagues. I represent the OpenText and the Dell company. Together they did a number of projects linked to the systems of health systems. So it works. Indeed, it's easy for me to tell you about our story of implementation of our applications in Nordic countries, because we've heard today about the success made by Nordic countries. Denmark was mentioned, Finland was mentioned as the more advanced countries that introduce the system of e-health system, and it was easy for us to see that to hear about the experience of those who implement this in the field. We've been working with 3 countries. In Finland, we set up a national platform, an archive of images. In Denmark, our technologies are used for exchange of clinical documents. We also work in a number of regions. In Norway, we set up a project on the exchange of personal medical records exchange. Today, I'll be placing emphasis on two countries. First of all, because of the time constraints, and Norway is somewhat different from these two countries in that basically it's a raw material-based economy, and the issue of reduction of social expenses is not so acute. The budget deficit helps them in this situation compared to Denmark and Finland. If we look at the country's profile, you'll see that they're quite similar, comparable countries in terms of population, but different in geography. And this defines and determines, in a sense, the way these two countries have been developing with regard to the introduction of e-health systems. If we are to look at this slide from the years 2000, we've seen an active consolidation of health facilities and medical personnel, and though we've seen a reduction almost 2 times, Finland is large in terms of territory, in terms of area, 8 times larger than Denmark. Actually, we see there a greater number of medical facilities, institutions. The need for this number of facilities is being questioned at the moment. In terms of reforms, we share in this subject, and it is discussed separately, although they have to be hand in hand together jointly, or have to precede the introduction of information technology. If we are to look at the way these things were interconnected in Scandinavia, the objectives set before the health system there on the right, that's accessibility of health services, selection of health institutions, some centralization, the emergence of new national services, they have to be reflected in a way in terms of systemic approach and in terms of introduction of information technologies. In terms of systems reforms, we see that both in Finland and in Denmark there occur consolidation, aggregation, and this is due to the fact that originally the structure of management administration does not allow the fulfillment of new objectives that are set vis-à-vis the health systems. And although it happened in different periods in Finland and Denmark, we see quite a significant consolidation and the transfer of funding to the national level rather than from the municipal level. In terms of success in implementation of reforms, and we'll see that later Denmark embarked on reforms earlier than Finland, and as of today they have a more aggregated pattern in the regions, and the funding is transferred to the national level, and the main emphasis is placed now on the setting up of specialized centers, whereas in the past they had more than 200 preventive institutions. Now it's 70. Then the emergence of specialized centers does not increase the number of medical institutions, and more than $1 billion have been spent to date in the past 2 years. If we are to look at the way information technologies make it possible structural reforms, to conduct structural reforms, we won't see consensus in the society and in the EU at large. They don't have a clear-cut understanding as to how to assess the efficiency from the introduction of eHealth systems, and based on different reports, and we've seen WHO reports today, and we're happy with that because it's quite recently that WHO began assessing and evaluating the maturity of the health systems, and this will in a way show us better how successful different countries have been in the introduction of eHealth technology. But we can distinguish two components in the attempts of to assess the ways eHealth systems perform. First of all, the quality of services, this patient outcome, which is larger than just the result of a particular treatment. And the second thing is losses in fraud and waste management. And as I prepared this presentation, WHO expanded the qualitative definition of patient outcome. They added 5 more parameters: the access, information, provision, waiting times, time saved, and burdensome travel. This is especially relevant for countries where medical aid is quite remote from place of residence. It's not applicable to Denmark, but it's quite applicable to the Finnish health system, which is scarcely populated in its northern parts in Lapland, with scarce and far in between centers to provide health services. There have been attempts in the past few years to assess in money the benefits of eHealth systems. There are different calculations. You see the figures: 0.03%, 0.75% of GDP that can be brought back to the budget if adequate steps are taken or have been taken in terms of introduction of IT technologies. You see a great variance because different countries started at different periods. If we take Nordic countries that have been implementing these systems in the past 15, 20 years, so when the data about assessment of efficiencies started to be collected, an increment in efficiency was not distinguishable. At that time, though later comers, they demonstrate high efficiency and more benefits. Now, in terms of qualitative parameters and in terms of reduction of expenses and return on investment due to introduction of eHealth, this patient outcome parameter, all translated into Russian, the internal assessment and evaluation of the system, its benefits in terms of benefits of the reforms. It's not applicable only to IT information technologies. It's generally applicable to reforms, and the key performance indicators, they basically cover cases of cancer and cardiovascular diseases, and that satisfies, as of today, the health ministry. They've reached the indicators, and the internal Kanta is a structural subdivision of the Ministry of Health that is responsible for national electronic record in the country, and they expect a return of 184 million, and they account for 25% for electronic prescription. We, under the electronic record, I mean, they're paid for by the municipalities and the hospitals. We're talking here about the exchange of data. They calculated the return on investment. I think their figure is 150 million. You can see it. I mean, there's an actual report by Kanta in the country, and we can see that. And what's interesting, you can calculate again how much money was spent to construct this information system, or let's call it eHealth. But again, you have to separate these two notions. There have been a lot of questions. What is an eHealth system? What medical electronic systems are? What will happen? What will be the evolution? So in this respect, Scandinavia is an example of how to divide these elements. So since they have this counter organization that deals with electronic e-prescriptions, and there will be a separate system that will be promoting telecommunication services. So we say that these calculations were done for electronic medical card, for a portal that provides access to electronic prescriptions and the management of rights of access. So this return is expected this year. So all investment can be calculated, and you can see the benefit from the. So you can see that Finland spent about 100 million euros to set up these systems. That was the annual expenditure. So one of the reports that I looked at as I was preparing this presentation to understand what was happening at the level of the EU and who are the leaders and who are the outsiders of this process of implementation, of introduction and implementation of an e-health system. It's an interesting report. I recommend that you read it. It's published on the EU website. It was made by a research institution in Poland last year. So you see the data for 2016. You have to take that into account because it's the situation is very changeable. It's changing fast. And with IT, it's always the case. So basically, the Nordic countries, Scandinavia is in the leaders. Denmark has overtaken all of them. It's a leader compared to Norway, to Finland, even they're leader in the EU and even in the Nordic countries. And they used 4 parameters: access of visit to a doctor, then the coverage of the prescription. It's not just an ability to have an e-prescription instead of paper prescription. It's larger than that. It means issuing of a prescription and control over the availability and also dispensing of the medical drugs. First, health info service availability 24/7, and the fourth means usage of online appointments and usage of e-prescription by GPs. It's not sufficient to provide this service at the national level. It has to be used, and we've seen the example of Estonia. It's very similar to the Finnish situation, very deep penetration of email e-prescription, and each of the leading countries, they have 100% penetration of the primary level. Even now, the way the Nordic countries have have implemented informatization of ICT, and first of all, they're not in a vacuum. They're defined by the framework set by at the national level. It's supervised by the Ministry of Health, Ministry of Communications. They define the architecture. They define the way the process should be constructed, the launching of the process. It's a quite comprehensive set of procedures. It's a large involvement. That means a large involvement of professionals from the ministries, the subdivisions in line ministries. It's dialogue with society, which is very popular in the Nordic countries. I mean, here, the patients' associations, they affect significantly the way e-services are shaped in the country, and WHO has already mentioned that Finland is an interesting example. What the email health system was one of the first e-services, and what we now call an e-patient. It's gradually transforming into an e-citizen. It's a platform which is now used to develop a citizen cabinet. You can see it from the map or image indicated by the Ministry of Health. I tried to compare the main stages in the evolution, the development. I wanted to point out the fundamental difference that allowed Denmark to get ahead of the rest of the countries. We see that in general, in terms of the objectives and tasks implemented for 15 years, they are similar, both in case of Denmark and in Finland. And we see that structural reform started at different periods, whereas in the case of Finland, investment was made for 15 years in standardization of the construction of national platform, and did nothing in terms of consolidation and centralization at the level of the health systems in general. Denmark in 2007 started to do structural reforms in the health system, reduced the number of hospitals, made larger institutions, medical facilities that made it possible for them to provide better access to medical facilities. At first we could assume that in 2007 we could say that there were serious mistakes made, like the system in the UK, when they admitted that they made mistakes as they constructed the system of the health system. We could assume that the same happened in Denmark. Indeed, they just pulled out the systems that were built in the regions, and they did an early adaptation. You cannot, it's a lost experience, wasted experience, because those standards that were tested on the regions, in 2007 they were made national standards. So you cannot say that from 2007 to 2013 they changed them. They just used regional achievements. They bought ready-made solutions from different vendors, suppliers, including us. They started building their national platform, and by 2013 they had achieved to do that, whereas Kanta launched in 2007, 5 years earlier than Denmark. So at the national level, they didn't allow them to achieve the same expectations they set on the return on investment. Earlier in my presentation, I said that now the plans of the government in Finland set objectives to save 3 billion, and that's the plan for 2030. Denmark can afford reinvest the funds into the setting up of new medical facilities. I will not dwell in detail on that. We've been working in Finland for a long time. This is a detailization of the development of the eHealth system in Finland. Here we highlight standardization system and the activity in Finland's activity in international exchanges. They are one of the drivers of what we call cross-border exchange, like exchange of e-prescriptions and electronic records. When the EPSAS project was implemented, a lot was done between Western Europe and the Finland. A commercial. So far we have this exchange between Estonia, Finland, and Sweden, but hopefully we'll see an international exchange. This is the architecture of the counter system. The objective is not to show how it is done, because architectures basically are similar. What I wanted to emphasize here is that now all this information relating to Finland, to Denmark, you can download it from internet. This is one of the examples of how Scandinavia works on practically all of their projects. All this information is accessible. It's published in the national languages, in the English language. It allows us to conduct, it allows them to conduct dialogue, broad dialogue inside the countries, but also at the international level. Were it not for international dialogue, they would never have emerged in the domestically. Then HIMSS annually assesses priorities. Basically, we're talking about Scandinavia. So priorities in the Nordic countries are not in the part of eHealth. They've been implemented. They are basically focusing now on more in-depth interaction with patients. As for the portal, I like the way we discussed the portal, the Danish portal. Its depth has been touched upon too. Indeed, it's a very saturated portal. It's much more saturated than the Finnish patients portal. I will skip it further, but in terms of today, what's happening in each of the Nordic countries, what are the key objectives of the current development in the Nordic countries? Where do they invest today? First of all, there exist certain global trends. Each and every country has been talking about that. Each and every conference has dealt with that. The important element is, and it's been touched upon here, if the health system is making a lot of expenditures that go to waste, so the saving is not if it is only 1%. Basically, the share of expenditures is 7% in EU. In Scandinavia, it's 9.6, 9.4 of GDP. So we understand that we need to find additional sources of funding to set up new systems, and Scandinavia tries, through their joint efforts. They're small countries, they try to unite their efforts and try to find ways to monetize what is happening in their health system. So we understand that the data being accumulated about patients, this is an opportunity for monetization. It's an opportunity to create new things that were not accessible earlier. There are farm companies, there are joint developments, and what we see here is an attempt to set up an association at the level of Nordic countries and to try to use larger arrays of data to create larger masses of participants to attract companies into investment. The next element is value-based care. Value-based care to move from an assessment in qualitative parameters to quantitative. We need to change a system of assessment and evaluation, and we need to apply new economic models. New economic models are not acceptable today without the use of IT, information technologies, because to set up and construct what's going on in health systems today, especially if we include here the patient, and we want to analyze data that we get from the patient, and we want to improve the quality, to assess the quality. This is one of the parameters. We call it from patient report, чтобы работать, to work with this and to understand the correlations with clinical quality measures. They are the main parameters that many countries try to assess to see how value-based they are, and they're using it for qualitative rather than quantitative systems. So you need the artificial intelligence tools. It's a buzzword, we call them that way, but without these tools, without these instruments, it is impossible to build a new economy in a health system. And a small self-advertising element, our work in Denmark and in Finland, and especially our work with the new untested parameters, PROM and CQM. We need R&D partners in research institutions. Dell and our company, we have been working with Harvard Medical School. They are part and parcel of this scheme. It's one of the largest training and learning programs in the east of the US. They invest a lot in models to analyze patients' data for the quality of providing services. They're interested in interaction with different countries. They are limiting their cohorts, even if they have an area of 10 million patients. So when they begin to interact with countries, they get 5 to 10 million new data. So their interest is understandable. So we try to see how applicable they are in clinical practice developed by Harvard Medical School. And basically, in summing up what I've just said, I'd like to point out a few main points. First of all, that eHealth is not in a vacuum. It has to follow the structural reforms in the system of in health systems. First of all, our experience has shown that centralization and consolidations are key elements, and perhaps we do not need thousands of hospitals. Maybe we should limit us to a couple of hundred of them. It depends on particular countries and geography. However, we come to a conclusion that we need to consolidate in general our health systems. And furthermore, this brings it up to a situation when we need to have national standards. We need to have less fragmentation in information technology, again based on the Danish experience, so that we do not need to reduce and normalize this part of IT information technology after we've done structural reforms. And in general, the last point I mentioned, new models, they are not applicable without new information technologies. It's clear without this we cannot talk about qualitative changes, our transition to value-based care. We don't have instruments without that for value-based care. Thank you. Thank you for this very detailed information that leads us to think about many interesting things. Next thing is the experience of electronic health systems creation in Brazil.
We'll make some amendments to our conference. The last presentation in this session will be transplanted first to the afternoon. Therefore, dear colleagues, please just keep some patience.
Thank you very much. I'm sorry I don't speak Russian, but I took a lot of notes this morning, so I have to say thank you very much. Dear Minister Maloshko, you were asking for best practice. So I'm going to try to give you some best practice. Two good news. First, it will be a short presentation. Second good news, we cross the ocean and we go to Brazil. So you may have already noticed I'm not Brazilian. I am French by nationality, but I just came back for 6 months in Brazil. And why Brazil? Because Philips has a business totally dedicated to electronic medical records. For more than 20 years, 60 plus employees have been and are developing electronic medical records for hospitals and clinics in Brazil. So there is already some experience there. And recently I was basically talking in front of a group of more than 200 CEOs, so Chief Information Officer and CEOs of leading hospitals in Brazil. So I would like to share with you a little bit some of their insights about eHealth. Now, on a personal side, my wife is Brazilian, so I'm a little bit biased. Now, Brazil, like any other big countries, are facing, big transformation. And it comes from chronic disease because the population is aging to managing the cost. And I think my talk today is really highlighting the importance of digital technology. But I will use very pragmatic examples. Well, Brazil, it's 40 times Belarus. Just to set the scene. It's a huge country, so it's 50% of Latin America. And then you may ask yourself, what are the challenges that they have? Well, in 1980s, they decided to give free access to healthcare to the entire population. I stress that. Equity of care and access of care to more than 175 million people. The day after, there was huge people queuing in front of the hospital, trying to get this care that they deserve, that their family deserves. And well, the hospital can decide to shut down, or they can decide to take this as a challenge and an opportunity to transform. And what Brazilian hospitals did at that time, supported by the Brazilian government, was basically to use and to embrace digital technologies. And they started by implementing electronic medical records for their hospitals and clinics. And the result of that was basically to drive three things. One, patient safety. I think it was Peter that was mentioning, and you, Claudia, as well, the transparency. So basically, everyone could know exactly what was happening in the hospitals. Then there was as well an important element around patient engagement, because then the patient could see exactly what it was happening for them. And as well, just to give you an example about the efficiency of IT technologies, by implementing those kind of systems, hospitals have been able to reduce their inventory by 30%, 30, because they know exactly where the drugs are, where the technologies they can use. Of course, it requires a lot of changes for the people, for the nurses, for the doctors. It doesn't come without a pain, okay? But I think it's worth mentioning that. Now, the result of that is that some leading hospitals in Brazil are already achieved a zero paper goal, which means that there is no paper in the hospital. It's what we call stage 7, 3 of specific ranking that we see from leading institutions like IMSS. Now, I just want to give you one example. It's a group of hospitals that are basically managing 5 million patients, half of the population of Belarus, if I'm correct. And basically those 30 hospitals, they run with one unique EMR that basically run into one single database, and this drives very strong efficiency because then they can do integrated scheduling, so they know exactly what are the patients that are coming, and then they can schedule the nurses, the doctors, the equipments according to this workflow. Now, let me give you one example, and I like very much what Elena was saying this morning, is that eHealth or electronic medical records in this case of hospital drive full transparency of data, but help the physician to take the right to make the right diagnosis. Okay? And because basically they get the information on the fly. And this in a kind of clinical context. Now, the very good news is that the more you use that, the more you get a lot of data, and then you can drive some intelligence out of that. And this is your example of big data and what we can do with that, because then you can inform and help the physician to make better diagnosis. So it's a positive cycle. You collect data and basically you mine those data and you make sense of those data. I can't resist to show you that one. David Wilson. It's a patient in the ICU. Oops. Let me get back. Yeah. It's a patient in the ICU, intensive care unit. And basically the system is collecting. Why it's moving? Okay. Let's stay to David for a second. The system is collecting data. Can you help me over there? Up. So the system is collecting data, and the system is already highlighting for the physician the right information, put in red. And then on the right side, you see that based on this information, the system already helped the physician to understand what is going on. So we combine descriptive and predictive analytics. Now, having said that in the hospital, then you understand that we can share as well this information, and it was the point from Peter as well, and from you, Elena and Claudia, about the importance of having patient-citizen engagement. So it's not only good to give the right medication, but to make sure that the patient is going to follow the prescription, is going to do the treatment. And this connection between what is happening in the hospital and what is happening at home is so important. Okay? And with that, you can rise to the next level, because when you have this information available at the hospital and as well having the engagement of the patient at home, you can have really what we call population health management. Now, there was an important information shared by Peter this morning, which is this connection. Because you have EMR data, because you have imaging data, because you have pathology data, because you have genomics data, you can really help making better diagnostics. And I cannot resist to give the example of oncology. It's only by combining those different elements that you can better get better treatment and better diagnosis first and better treatment for oncology cases. Now, let me conclude with that. I strongly believe that healthcare, and especially in Belarus, needs to be networked, needs to be predictive and precise and accessible. Now, I strongly recommend you, for some of you that are able to attend, there will be some presentation done by my colleagues tomorrow that will go into much more details about these elements of digital health platform, as well as the importance of interoperability and standardization. And this is for me really something that helps data-driven solution. And now, when you have that, then you can really claim a population health management and a value-based health care. Thank you for your attention.
Спасибо большое.
Thank you very much. And now, dear colleagues, so at 2 o'clock we'll be within the service, and they will give him advice using specialized service. Both doctors, both doctor and physician in the outpatient clinic can see the same image, can see the same text or description, and all the additional materials which are referred or are related to the patient in the form of their assignment and additional attributes. Teleaudit. It is radically different to what I have said before. In this case, the doctor doesn't request from the outpatient clinic the information, and the procedure is different. In order to have the monitoring of the service of beam diagnostics, we, out of all the research, we pre-select at random about 10% of all the R&D which are distributed by subspecialties such as neuroradiology, muscle radiology, and additional 7 subcategories. In our center, we have dedicated experts, totally there are 22, and they describe those pieces of research irrespectively whether the primary level doctor wants it or not, in order conventionally to find out the temperature for the entire hospital. We have to know the discrepancies. We don't call them errors, just discrepancies, clinically important, clinically insignificant, general remarks, and so on. And based on the results of those assessments, we generate ratings, reports, which automatically are presented to doctors, to the head doctor, and thus generate ratings of the entire organization and provide the data to public health department. Actually, the process on audit is a series of actions. First of all, selection of the type of the research, generating the analysis on technical manner of the research, which evaluates on how the technician has worked on the research. Then it is evaluated by the third-party expert, and ultimately it generates the final assessment for the research, which is the latest icon. Based on the audit, we can develop the training for X-ray technicians, for doctors, those assigning, and also the patients, in the form of methodological recommendations and informational materials before the cabinet of CT or MRT. We managed to confirm that our actions have resulted to 49% reduction of clinically important discrepancies. Based on the same data, we can generate ratings of medical institutions, and we present the data to the managers of different levels. Thus, for instance, we managed, based on the parameter of shortening the time of description, we managed to reduce it from 58 hours down to 8 hours. Previously, we were unaware of the timing. As I have told, for each X-ray doctor, there is the generation of an individual rating based on discrepancies or the entire conformity based on the audit, irrespectively of the willingness. Here we have quality example on improving professional career of one of the X-ray doctors. In the right bottom column, Actually, to this process, we have connected the attestation and counseling departments as well as the training department. And throughout the past year, we managed to train about 17,000 people from 87 cities. I cannot even imagine how many people we will train this year, but the number will be quite significant. I'm happy that those sequential steps in training the professional community, both free and for money, will impact the performance and the results of the beam radiation department. And now telemedical counseling. I will just take two processes, centralization of descriptions and cross descriptions. So the idea was as follows. In the medical agency, we have the key organization and its daughter or affiliate focal points. When connected to transformation service under some methodology, it became possible to reduce the number of doctors in the daughter focal points and redistribute the burden in the form of description of the research into the central medical organization, the headquarters. Thus, it became possible for one medical organization to have the saving of 25 million rubles. At the same time, the salaries of X-ray doctors have increased. And now cross-description. For instance, when we have got a patient into the medical agency with a particular task for examination, then each of us, both physicians and the patients, will be happy to get examined by the specialist. But the person doesn't know to whom in particular. Therefore, we have consolidated a pool of experts. For instance, those describing the chest, and that person with better accuracy and better quality will describe such a research, but not MRT, of the head brain, for instance. Thus, we subdivide X-ray doctors by sub-professions in order to improve the quality and the performance which they describe. The research done in one place will be described in the place where the subspecialist is on particular diagnostic task. We have also been piloting the opportunity of performing research in the medical agency without contrasting, without X-ray specialist, for such a research to be described in the absolutely different medical organization. This will result in saving the costs significantly and thus improve the salaries, if I may say so, for expert doctors. Therefore, having analyzed the results of the project, we managed to increase the number of results of the entire compatibility and diminish the number of discrepancies. Teleradiology, as I have said in the past, managed to review the opinions on staffing and on salaries, review the productivity, as a result, we improved the quality of descriptions of research for beam diagnostics in the agencies where those projects were undertaken. Actually, YERIS is the PACS-RIS, and out of the database through YERIS doc we can generate dashboards, business intelligence, with the help of which in the online mode we may assess and evaluate all the changes we have taken place in the service of radio and beam diagnostics of Moscow. Here we have an example of dashboard, and here you see the parameters which we collect every 3 seconds and update. For instance, from the early morning at 9 a.m. we know which instruments have already been switched on, which doctors have been describing the processes or which pieces of equipment all of a sudden ceased working. We immediately communicate the places, and through the help of our remote centers will be able to redirect the patients to the less involved centers. So a patient who was supposed to examine in the organization where the equipment is out of order doesn't lose time and gets the service immediately that very day. One of the examples of dashboard operation, these are the results and the number of pieces of research for 2017 on outpatient organizations without contrasting. Of course, the usage of such the massive of data is needed not only for monitoring but for R&D as well. Of course, we have an opportunity of making the marks and set ambitious tasks for artificial intelligence and intellect. Here we have gotten examples on retrieval of for retrieval of inflammations in lungs in order to have lungs cancer examinations. This might be the solution for different types of people participating in clinical diagnostics process. And who help the patients in getting the necessary services. Presently, ERIS is not a mere piece of equipment storing information, but it's also the tool of irradiation diagnostics equipment in Moscow. Teleradiology today is the constant element of improving the services, and such a tool will work perfectly in experts' hands. Thank you for your attention. Thank you, Victor.
It's a very important statement, important remarks in terms of management and administration of treatment. Hopefully, those present in the room will be ready to use this experience now. The next speaker is Sidelnikov Oleg Nikolaevich, Director General of Big Cloud Company, who will be talking about digital transformation of the health system based on the Republic and the national platform. Thank you. I'll be brief in my remarks. We will be talking about the operator's role and the way they can take part in the eHealth system. About our operator, it was set up to create and operate facilities of information and communications infrastructure. The main objectives that were set by the state was accelerated development of the ICT infrastructure and the market of telecommunication services, increasing the accessibility of infrastructures and of the networks, also the introduction of cloud services and cloud calculations. The global trends in our health system are similar to other areas of activities, of human activities. The development of artificial intelligence technologies, big data technologies, then challenges to cyber security, analysis of big data and information security. We're talking now about the security of medical information. The key drivers are given this data. This notion of digital of e-health system are not new. The main factors are given in this slide. The artificial intelligence, mobile devices that allow us to use to provide medical services. Cloud technologies, they are the instruments, the tools that allow us to conduct this transformation of the health system. With regard to infrastructural foundation, This is what the Belarusian cloud technologies provide and which can be used in digital transformation. Their unified system of transmission of data, the Republican, the National Center for Processing the Data, and the National or Republican Cloud Platform. And as for the implementation of the Republican and National Platform and Data Processing Center, it is they are executed based on the Presidential Edict number 46 of 23rd of January 2014. The aim is to optimize the expenses. The Belarusian Cloud Technologies is the main company. All national and authorities are supposed to transform the resources using this platform. This is, in brief, a topology of a unified system of data transmission without technical details. It's based on DWDM technology, which makes it possible to use a couple of optical fibers, 4 terabyte data flow. It can be ensured high reliability and error-proof transmission is ensured. So this is a transport network that is available to the operator. As for the data processing center, it was the construction was completed in Kolodishi. 12 hectares of land was used for that facility. The Emerson company, data center, and Facebook are also constructed with the help of this of the Ericsson technology. Few digits. It's based on prefabricated design. Up to 4 modules can be achieved. 24 racks are used, and making use of the area that was allocated to us by the government, we can build more than one data processing center. We have one main and one backup facility. We can do scaling, and Caterpillar company has provided its product for 4 modules of the data center. Capacity is up to 4 megabytes, and which the international certificates and awards have been provided for our solution, which means it has a high level. We have certification for PCI DSS, which is basically relating to the reliability of the banking system. And back in 2016, our project was recognized as the best at the Russian Data Center Awards as the best solution in the CIS countries. I'm mentioning that for you to understand that this solution is a very good one, a very reliable one, and it really allows, it makes it possible to deal with the challenges faced by the health system. The functions are the placement of software, then using SLA. It can be used for protection of information, also to provide a wide range of services that are required by the health system. In terms of protection, the slide here shows the main elements of protection of the platform itself. So the main aspects can be mentioned. The platform is built in such a way as to protect itself, to provide a protected contour circuit around it. Why do we need the cloud technology, cloud calculations for the health system. We talk here about a reduction of expenses, its reliability, flexibility, and the key aspect for the health system is protection of information, including medical confidentiality, and with account taken of the concept of eHealth, of an eHealth system that have been shaped in our country. We present here our vision, the central platform that's going to be set up by the health ministry. It will be relying on the Republic, on national cloud run by the state, by the government. In terms of contour of security, it can be expanded, and the concept has plans of placing at least 40% of medical platforms. The green dotted line shows the volume of security by the big cloud, but we should understand that inside the information systems are certified by the owner of the system. So what is required? We require additional systems of protection for security of the data, and the biggest circle shows the space within which we will be implementing this concept. As for medical information systems, all issues and matters, they will have to be dealt with as the platform is being completed. So part of the concept will have to be left to the local levels. As for our key clients and projects, they are given in this slide. The required level of competences are available to our company. The big cloud has shown itself as a reliable partner for government authorities. We plan to be continue to be a reliable partner for the Ministry of Health. Thank you for your attention. Thank you for the presentation. If you have any questions to ask of the speaker, you can submit them in writing. We'll try to deal with them at the end of the day or tomorrow during the roundtables as we conduct them. We'll try to respond to the questions raised. The next presentation is to be given by Shiltsov, Deputy CEO of the LLC Business Network.
Good afternoon. Continuing the previous presentation by Oleg, let me brief you about the example of digital transformation of informational space, taking Minsk as an example. At Oleg's slides, you've seen RSPD, which means the Uniform National System of Transmitting Data, and we are included into that data transmission system. We are a part of it. We have the connection with big cloud, and consequently provisioning of the last mile in Minsk is carried out by our company. Since 2014, we have been working on the project of uniting all medical institutions in Minsk. We were using our own funds for that, and let us see what we have achieved. I have to say that the Uniform Institute of Informatics of the Academy of Sciences gave us a helping hand, as well as the committee in Minsk municipality. Then, as intended, there will be plastic patients' cards, and you can book the doctor through the kiosk, through the registry in the acceptance department. The result will, as is clear, will be lower burden on staff and patients, fewer losses and saving of money. Corporate network of public health in Minsk, as I have said, since 2014 is connected to 120 institutions in the city of Minsk. We On top of the uniform corporate network, with the connection to cloud services of big cloud, we also provided quick access to internet, Wi-Fi networks in the inpatient clinics, or for instance in outpatient clinic number 35 in Minsk has got a Wi-Fi network as well. We have merged 35 city outpatient clinics on digital fluorography and 10 outpatient clinics on digital mammography. The results are as follows. Better efficiency of the performance, better access to high-quality medical assistance, and real saving of funds. Integration into the global network. Of course, Belarus is not an island in the ocean, and communicating with the colleagues in the other countries is a must, but I have to say that for proper communication of information in the unchanged format, and at the same time protected from the external impact, we have to provide some solutions. Деловая сеть has a solution on protecting communication channels and their crypto protection. Together with our partner, ITTS, that solution provides confidentiality and the control of integrity. Encoding also corresponds to the state standards in this country and to international treaties. The range of products for hardware is made of two things. Firstly, personal means of encoding. I have such a device with myself. It looks like a clicker. You insert it into a USB port at the back, the Ethernet, and gets connected via the cable. So there will be minimum speed of 10 megabits per second, which is the minimum for operating all the software from the cloud platform. The device operates with encoding server installed in the core of the network and which gets connected to remote working places. All those tools are certified from the operational center and they are in full compliance with the Belarusian legislation. You can buy and use them from the shelf. The main advantage is the simplicity, uniformity, good protection, and mobility. They are transparent for all the softwares. There is no need of tuning. You just switch it on. You connect Ethernet on it, and it starts functioning. You see its mobility. With it, you can easily move everywhere. It's not at all bulk. It's small, like a memory stick. And finally, I would like to share with you another project which we have been dealing with together with our partners, and this project is the system of telemedical dispensarization based on functional spectral diagnostics. Here you see a bit sophisticated layout, and let me read out some results based on the scheme. So, we have diagnosed 57 patients, and diagnostics was carried out for cardiovascular, urinal, sex, muscle, joints, bronchial, lung. 342 cases were examined. As you see, the entire time spent for making the entries and recording of the signal lasted 35 seconds. Sending for remote diagnostics total from 4 to 5 minutes, and the compliance of diagnosis was 93%, which I believe is quite reliable. If you want to know the details, you can visit our site. And let me also tell you about the company. We have been in place since 1998. This year, will celebrate our 20th anniversary. We are doing connections for the operators and also the Committee on Public Health. We have been working with the education sector and with legal entities, including retail and banks, catering. With the High Technologies Park, as you see, we are open for any collaboration. Our key area is rendering reliable high-speed communication channels for the last mile. Thank you.
Thank you, Dmitry Vячеславович. The business network деловая сеть, they've performed as a very reliable partner throughout Minsk. The next speaker will be talking about the experience of creation and introduction of eHealth systems in Croatia, Armenia, and Kazakhstan. Ms. Domagoj, I'm not Domagoj Turk, I'm Zlata Smirnova. Good afternoon, dear listeners. I'm Zlata Smirnova. I'd like to thank you, first of all, for this opportunity to share our experience. Ericsson Nikola Tesla obtained and the lessons learned in the course of implementation of its projects in Croatia, Armenia, and Kazakhstan. First of all, briefly, I'd like to introduce Ericsson Nikola Tesla. It was set up back in 1949, and starting from 1995, it joined the group of Ericsson companies. Nikola Tesla has a strength of 3,000 persons. They're engaged in comprehensive specialized solutions for industry, for the society, for the health system. Starting with the year 2000, we started our close work in the health sector, and we started with a number of investigations that brought about solutions and the introduction of an eHealth system in Croatia. We have been supporting it to date. We've been developing this system, and we've been improving that system. Our many years of experience in eHealth systems covers the entire world, but this one is dedicated, this presentation is dedicated to eHealth systems in Croatia, Armenia, and Kazakhstan. You can see our latest projects on this map. More than 15 years ago, it started with consideration of a comprehensive system of health that was focusing basically on processes and service providers, not on the client. And processes were fragmented, isolated, poorly managed. Processes were fragmented, isolated. The processing of orders, requests was done manually or on hard copy circulation, that's paper circulation. The exchange of best practices did not occur, or it was done on an individual basis. And as you begin to think about expenses to be incurred in the future and the quality of such a system, you are faced with a number of questions that you have to respond to. Yes, this was the system in Croatia at that time, so we began to think of what we can do, what should be worked on, what is the best way to deal with that, and it would have been much better, we thought then, through investigations, if a health system was focusing or were focusing on the patient, if expenses were made in a transparent and centralized way, if the health system could rely on evidence, if processing of a request or order was automated, if best practices were used that were exchanged among all the participants, and the information could be centralized, accessible from any place, any time of the day. How can we achieve that goal? No doubt, information communication technologies can play a role. significant. However, it's not the only component. We need also to conduct reorganization, introduction of new processes, along with the acquisition of new knowledge and competences. Thus, to achieve the goal set, we need to conduct a substantial and comprehensive transformation. A number of questions arise. We have to find the response to them. What is the way we should collect information, then spread it among the participants? How can we trust the information, and how to measure success and at what stages? But the most fundamental question is, where shall we start with? Thus, a national health system can be presented as one puzzle, big puzzle, which has to be put together piece after piece, and we have to start rather with small, very simple, but at the same time very important parts, such as key registers of patients, registers of medical staff and personnel, then to introduce an e-prescription, request for a visit with the doctor. So at the end, you end up with a greater part of the puzzle that will make it possible to go further with the introduction of electronic medical cards, so that each patient, each individual can see the status of their health. Then it is followed with other components of the puzzle, that's getting reports on tumors, malignant tumors, setting up programs, health programs in place, then prompt information like on status of insurance, addition of functionality, for example, physiotherapy. And then further on, you can go on and on about the ways of how to improve an health system. The national health system involves a great number of subjects or operators. You can see them on the slide. They're not all of them there. Of course, the most important subjects are individuals, citizens, then followed with physicians and medical workers, then facilities or institutions of the health system, drugstores, outpatient and inpatient clinics, executive authorities, all sorts of departments, agencies that are responsible for a specialized treatment like physiotherapy. They have to exchange information, exchange data. They have to be connected with each other. However, its connectivity, their connectivity, direct connectivity does not help a lot, because some information can get lost. So we need to think of how what to do about that. One of the responses, one of the solutions that would be rather satisfactory solution will be to set up a national integration platform that will allow the subjects and operators to share information, or as one of solutions, you can end up with putting it all on a cloud environment. Let's look at the way it looks in Croatia. The official name for this national integration platform is CEZIH, which is the platform makes it possible to support different business processes, such as e-prescriptions, direction for a visit to the doctor. It also it includes the central platform was developed and is being developed now, and it is supported by the Ericsson Nikola Tesla, and together with this it is surrounded and integrated with more than 20 applications from different companies. The implementation of the central information system and its services in Croatia occurred through the implementation of a number of stages. You can see them on the slide here. Each of these stages lasted at least 1 year. So everything became possible based on the research done by the Ericsson Nikola Tesla, with the involvement of different medical personnel and staff involved in the health system, the data obtained, and with the involvement of medical workers. served as the basis for the development and implementation of the platform. Thus, everything started that the first aid was placed at the foundation, and it is a system of family workers, pediatricians, gynecologists, and dentists. At the next stage, it was possible to introduce national preventive programs, electronic registration of visits, then other functionality was brought in, and it was crowned with this system, electronic system, was crowned with an electronic medical card and the portal for patients that makes it possible for each individual to get access to information on the current status of their health. Now we have a platform that allows to integrate a lot of things, and it contains a lot of useful data. Now we're doing the implementation and introduction of a reporting system. We're hopeful that in the future we'll have a lot of functionalities, additional functionalities that will be beneficial for the development of a national system in Croatia. And the electronic health system in Croatia was widely recognized internationally. So the independent research center that I'm just giving the name of, they do the assessment of all systems across Europe, including EU countries, but they do not limit themselves to this. They do it in different categories, starting with 2011. Croatia found itself among the leaders in terms of the accessibility of e-prescriptions. And I'd like to note that e-prescriptions in Croatia, they are 100% accessible. This makes it possible for an individual to get medical drugs at any part of the country at any time. You don't need to carry a hard copy of a prescription. And in 2013, Ericsson Nikola Tesla got an order to maintain a system in Armenia. The official name is HISA. That's an integrated information system of health in Armenia. And it was very different from the health system in Croatia. And due to this, I'd like to note that apart from that, in Armenia, there were only a few systems in place, and an e-system had to be developed from scratch. Compared to Croatia, in Armenia, we used an open start code, original code, and a private cloud platform was used. All the operators and subjects used this HISA platform. As a result of this project, funded by the World Bank, was the creation and the implementation of a fully functional eHealth system in Armenia that was used by a selected set of medical facilities in a test mode. The government of Armenia decided to extend this experience, this solution, across the territory of the country through concession contract agreement with a company that would be developing the HISA. The Nikola Tesla Ericsson company is the supplier of a solution of software with a company to be selected, and it is called the operator of a national e-health system. Early in 2016, the Ericsson Nikola Tesla company started the implementation of the e-health system in Kazakhstan. The official name of the project is provision, a supply of a platform to informatize and ensure interoperability of information system in the system. In the health system, it's a very large platform. It's a very comprehensive, integrated solution based on a combination of technologies of open code technologies and private software. It includes an integrated system which involves 8 registers. It also provides for the introduction of a health passport. It makes it possible to provide services to 18 million patients. It provides for a patient's portal and doctor's portal. It includes a number of functionalities, reporting system, terminology platform. So the implementation of these 3 projects in the past 15 years has made it possible for us to learn lessons which we would like to share it with. Of course, we faced a number of typical changes. Any company would have the same, would have faced the same. First of all, the actual length and difficulty of the projects was underestimated, which ends up with the follow-up and the durability of the project and the implementation of national systems of eHealth. They are not just an IT project with the involvement of a number of parties. The setting up of such a system is a big, large-scale national project which needs the support and fulfillment of obligations, and it has to be by the government, has to be recognized as a strategic project. We would also like to know that political or personnel and staff changes has to be insured against. We face this problem in all countries because of the dropout of staff and personnel. People left the project, so we had the extension of the durability of the projects had to be suffered actually in the long run. The implementation of an eHealth system will involve a lot of medical facilities. You have to be sure that they are powerful enough, not only in terms of resources, but also the equipment, and so that we'll be able to implement the projects. If there is a great number of stakeholders and they're all involved in the project, you may face the lobbying on their part of the project that they want to impact and control the project in their own interest. The project needs to be protected against such phenomena. It has to be managed for the benefit of all. So the responsibility has to be defined and well defined and described. Absence of or lack of coordination can lead to problems in its implementation. So it's always good to have a powerful systems integrator that would develop, correct, adjust your actions on the project. And the introduction of a national eHealth system is part of digital reform. Some of the lessons that we've learned are presented in this slide. We'd like to share some of them with you and draw your attention to them. First of all, the development of a national health system goes well beyond the IT area. It needs to be looked at in the aspects of standardization, legal framework, the duration of the project, etc. So you have to have a vision of this project, and it has to be defined well in advance or at the very beginning. So the legal framework, the normative and regulations base which is to be used, so the requirements placed on them, they have to be developed well before the beginning of the implementation of the project. So if the requirements will change, if the regulations are changed, so the duration of the implementation of the project can be affected. So you have to remember about that. If we are to talk about the duration of projects, our experience has shown that the introduction and implementation of such a system cannot be done in a period less than 2.5-3 years. The first part is the most of the implementation is the most important, and this is the stage where you collect information, where you construct the entire concept, and the initial stages have to be short, and they have to be started with small steps that would be beneficial for all parties involved. This has to be visualized, but this could be an impetus that would help everyone to understand what the goals are, what our intentions are. So the pilot project is very important for a region, for an individual hospital or polyclinic. We need to see how we should adjust our work, and only then we can extend this solution to the territory, to the area of the entire country. We also need to listen to feedback that we might get during the pilot stage from the users. Thus, if we are to work on the system and to involve into it the users, the end users, then the construction and the development of this eHealth system will be going on in a natural way and will be painless and seamless. As for the project team, do not allow the IT team to control and manage the project. And I'm talking that based on our experience. We need to have a good understanding of the domain in the health sector. You need to have a good vision of the processes and transformations that are expected to occur. So the core of the matter is not the process and technology, but the understanding of the processes and their order. Technologies are only an instrument to implement those processes. We need to have an understanding where we're going, what our intention is. Then technologies will help us to achieve the goal set. Do not allow the selection of technology to define the system. It's better if you don't have any influence of those technologies on the definition of the system. So at the beginning, you need to identify which systems will be left in place, left intact, which of them will be changed, and then you have to go in a due manner about the identification of the interface. So the existing system should not be a starting point in the introduction of and deployment of an eHealth system. It should be vice versa. The standards are, of course, a very important subject matter. They're an important component in the development of an eHealth system. However, we should not overdo that. Trying to introduce the latest standards to look fashionable or to look up to date. The new standards are good, they're interesting, they're promising. However, they have not been tested by time. They have not been worked through in practice. Even those that have been tested, they're not ready yet for use, for application. They have to be adapted for a particular country and for a particular system. Also, you should not overdo with the specification structure. It's impossible to go into each and every detail describing each and every component in the next system. No doubt there are parts of the systems that have to be presented in detail. However, you need to leave some leeway for the physician who is supposed to make use of the system and could be in a position to leave their commentary on a problem, on a certain disease, and not just using templates from an established and set and fixed list. Of course, the platform would include hardware and software. Anyway, each country faces procurement problems, and procurement is connected and interconnected in different senses, but it has to be thoroughly organized, taking into account what I've said before. A concept is identified, then solutions and software identified for the concept, and then based on that, procurement for equipment is done, and this equipment will be later on used for the implementation. Then the project is completed, and end up with a fully functional system, like in the case of Belarus. And we will have to develop it, support this system, and at this stage, we, from the very start, need to have an organized group in place or an organization that would be doing a follow-up servicing and support for the system. And at the end of winding up our remarks, I would say that it's always difficult to start, and in health systems too. So you would always face a great number of issues of different nature, legal ones, for example, issues relating to the architecture, to the techniques, motivation, opposition of the end user. You cannot have quick wins, and an e-health system needs time to achieve the goal set. So the essence is not technology, but the understanding of processes, understanding of the end goal that is being set by the society at large. Technology will change both during the life cycle of the platform, but the essence, the substance of the matter is, the crust of the matter is understanding of what we are driving at. When you select a partner to set up a platform, you need to be careful in selecting your partner, not only just the ready-made, so to say, supplier or vendor of a solution. You need a company that will be able to help you in developing and achieving the goal that you're pursuing, and each next step will be easier than the previous ones, and the benefit will be growing in terms of its impact. And there comes a time then when you feel an impetus, a powerful fillip, the maximum benefit you can get from an newly developed e-health system. You should not miss this point, this moment, and I'd like to wind up with an excerpt from a WHO report that speaks about the situation in Europe. And so this report basically says that there's no one single strategy applicable to all countries that can be just juxtaposed and on a country and implemented. Solutions depend a lot on the social context in each particular country, and what is really important, what is really applicable absolutely everywhere is the principles, experience, acquired competencies, and clearly defined criteria of success. This is something Ericsson Nicola Testa can contribute to such. And if you have any questions, you're welcome. Thank you. Let's thank Zlata for her remarks.
If there are any questions, you are most welcome. Our next speaker, and the topic will be interoperability and integration of e-health systems, senior consultant on integrated solutions for care system.
This opportunity to talk about interoperability. Interoperability was mentioned many times this morning during the presentations, so I want to have a closer look at this concept of interoperability. Okay, you can hear me now? Great. So interoperability, so I'm working for Philips. Sorry, okay, thanks. So I'm working for Philips, especially for the group within Philips that's focusing on interoperability called 4Care. And this group is totally and solely focused on interoperability. But let's have a closer look at the interoperability. I don't want to bother you with too much detail, so I will promise to keep it short and simple. But I want to address the relevance of an open interoperability platform and the need for open standards and stage approach for the implementation. So when we talk about interoperability and the connection with eHealth systems, we're basically talking about bringing information and people together. Because the information is almost always available somewhere, but not at the place where it's needed. So the information might be in one hospital, but it's needed in another hospital. So the information is there, but it's required at certain places, at certain time, and at specific people. Is it something? Oh, thanks. So it's required at certain places, at a certain time, by specific people to accomplish specific goals. For example, here in the emergency situation. In the emergency, you need not only the information, the right information, but you also need the right information fast in order to make quick decisions. And in medications, for example, you need not only need the information, but you need the most recent information. For example, for patients, for medication safety, for the medication review process. And for the right treatment plan, you need the complete information about the patient. So the complete history of the patient and the diagnosis and the most recent information. And what if this information is already available for the consultant even before the patient enters the consultation room? So we talked about interoperability. Interoperability is basically the ability of systems to connect to each other and exchange information. But what we always tend to forget is that we should not focus on the technology alone. We should merely focus on the process and on the people that actually use this information. So I agree with the previous speaker, Zlata, that we need to focus on the processes. So we need to focus on the workflow and empower the people to use this information. So let the information flow seamlessly between the professionals in order to deliver high quality care and more efficient healthcare. So I'd like to introduce the concept of the interoperability platform. With this platform, you can connect all levels of healthcare. So the primary care, the GPs, the hospitals, but also the patient. And this platform you can use to exchange the information and let the information flow and use this for different purposes. Clinical purposes or healthcare purposes in general, like a referral, the exchange of medical summaries, for clinical decision support. You also need this information for maybe in the future business intelligence. So, and this interoperability doesn't replace all the systems that are out there, just you need to connect the systems to this interoperability platform. So this interoperability platform could be the backbone of your information exchange and might be very useful for your project. And at Philips we implemented a lot of these kind of interoperability platforms, and I want to share you one example. This is in the region of Friesland in Holland. It's one of the regions in most rural areas in Holland, and I know rural means something different here, but still. We have 6 hospitals in this province, and they all send their cardiology cases to one intervention clinic in the capital of the province. And before we had this interoperability platform, they needed to send all the information by post or by fax machine on CDs, or even on old-fashioned videotapes in case of ultrasound. So the information was almost always very late, and the quality of this information was very poor. So, and then we placed this interoperability platform in this area. We connected all the local systems, so they were able to let the information flow from one hospital to the intervention clinic, and the information was in the original quality. And we were also able to add more information. So the result was that you have more information, a better quality of the information, they could speed up the process even by 2 days. They were able to report easily back to the referring physician, and at the end they were able to lower the overall cost of healthcare. I believe return on investment in this case was in less than 1 year. So I would like to give you, of all the possible success factors, I'd like to give you two of them. One is the use of open standards, and that's mentioned earlier today. And why do we need to use these open standards? One is to leverage the experience of earlier implementations. So there's a lot of information and experience and knowledge put into this open standards because they are developed over a long time. So I don't really agree with the last speaker that we should not focus too much on the open standards because there are proven technologies out there and they're used in a lot of countries. This open standards will also be a solid foundation for future growth. So there's proven technology out there. You can use it. You can start right away. You can start small and grow after time because everyone can connect to this system. You can easily connect extra modules to this interoperability platform. And because it are open standards, everybody can contribute. There's no vendor lock-in. The specifications for the standards are open and freely available on the internet, so every local vendor can contribute to this overall platform and connect to the system. And the system, the standards doesn't not only apply to the exchange of medical information or how you structure the information, but it's also about the security and the privacy regarding this information. And I want to mention the IHE. That's one organization. It's a joint effort between software vendors and healthcare professionals in order to regulate the standards and to promote them. And this is also acknowledged by the European Commission as they acknowledged and endorsed the use of IHE standards for interoperability. And the other suggestion I would like to make is use a staged approach. So define your use cases, pick one, and make this a success. Implement this, make this a success, and evolve afterwards. Based on your success, you can easily implement other use cases afterwards. So you need to invest in this base infrastructure that can grow with you over time. So you should invest in the base infrastructure that can support your first use case, but could add extra components to it afterwards for the other use cases you want to support. But you need to focus on on the use cases that support clinical uses, like the real clinical relevance. And what I also would like to mention is that using such an interoperability platform, you can also support a hybrid situation, because I can understand that everybody can automate their hospital right away. So you can connect the systems that are able to connect, but later on you can start using internet portals, or you can start with using internet portals to support the people that do not have systems in their hospitals or at the GP office. To conclude, I'd like to say that I would like to suggest to use an interoperable sharing platform to focus on the clinical relevance of your use cases, stay flexible by using open standards, and plan for the future and use a staged approach. Thank you very much.
Thank you for your remarks. Dear colleagues, we are left with two more speakers, so please be patient. The next one is a speaker who will be talking about international experience for national systems of eHealth The speaker will be Denis Filozafovich, Deputy General Director of the Welcome Company. I will allow myself the title. We, as of today, were flattered to get an invitation from the Health Ministry to speak at this conference. So this invitation is in fact a sign for us of the fact that we are in search of areas where we can be useful, beneficial for the Belarusian health system. As of today, we cannot boast of lessons learned or the competences or skills that have just been demonstrated by the Ericsson company. We cannot offer services that the business network has demonstrated. We, as newcomers, can share our observations. Yes, we have access to experience in our mother company, Telecom Austria Group. We are part of that group from 2007. They are one of the leading players in the European market, and they've just finished a project to update a system to ensure an IT structure for ambulances or first aid services in Bulgaria, also in Croatia. Our ways crossed there in Croatia with Ericsson. Our lesson, however, that we have learned as a company that have existed in this market for a long time, we think it's fundamentally important for us to focus on the provision of a basis and very important element as IT infrastructure. This presentation is a short one compared to the previous ones. It's only made up of 3 slides, but it allows us to focus on the main things that we are comfortable about. What are the characteristics that an e-health system must have, that our country wants to set up? I haven't heard it in the previous remarks. However, from literature and also in reflecting a liberal model, so to say, I learned that, in fact, the owners of the medical staff is supposed to be the individual himself or herself. Our company has been servicing 5 million live users. This statement is very clear for us. So we say that in terms of technology, an e-health system should be mHealth, because we see how quickly people get accustomed to using these mobile systems in their banking, in their daily life, in their banking, in their interaction with banks. So 4G, 5G technologies will be used, that is, through mobile phones or tablets. I don't think we'll be using it in a different way. My second remark is that the element or the characteristics of an e-health system is that this system should be centralized. It's difficult to imagine that the volume of data, volume of interactions that occur in the periphery with different players of the market, starting with polyclinics, hospitals, other institutions and facilities, including other players in this field. We understand that a great amount of investment is required. However, we don't think that we need all that. The telecommunications technologies that Zdravоохранение has been talking about makes it possible to do connectivity in such a way that all data can be stored centrally. When I say centrally, I do not mean that we should have one platform. Then it would mean high risk. We are talking about distributed solutions. So ideally, we should have at least two platforms. Ideally, even we should have 3 platforms, and they have to be operated by different organizations to ensure 99.9. But it should be even higher. It's difficult to imagine a situation when during an operation on a patient, suddenly some system stops or goes for a smoke or something. We cannot imagine a situation like that. The next thing I'd like to mention is standards. Professionals have been talking about standards. I'm happy that we are repeating their message: open standards, international standards, but with observation of national regulations. Belarus, it's quite mature. The regulations are quite mature. The data that we are going to use, personal data, super sensitive data. So these are very important that these requirements are in place. Our Philips colleague formulated it differently. Yes, the individual has a constitutional right to enjoy medical services, and the government, the state, are supposed to provide an infrastructure. So the place for the government is to set up a portal, and they have to take care that the data are stored in a safe, secure way. They are stored for a long time. However, the portal, by definition, should be open, and we trust in an analogy that in the same way as we consume media content from the marketplace, we do not think about the owner of the content. So the government, the state should provide an infrastructure, support. However, the access, the content, the processing, bring it to the end user in the most convenient way. It should be open. This access should be regulated, and we should have in place certain permit system, certification of the players. Only companies that have special competencies should be allowed to do that. The next issue, which was also touched upon, it's difficult to imagine systems in the future that are not built on adaptivity or pre-preparedness of working with large massives of data, with large analytics, artificial intelligence, machine learning that was mentioned by the guys from Moscow, where areas of data, massives of data, they're dealing with problems that are of global nature. You know, the disease we deal with in Belarus, they are not unique. So a system should be receptive to accept and support this data. And the last thing I'd like to mention, we business people, we find it important. We trust that there is a huge reference system in the world, but we suggest that we think about our country's ability or capability to deal with it. Our GDP is not bright. We have a very slow. We are very slow in our development, so we need to be reasonable so that we have a reasonable, prudent percentage or share of the GDP comparable to that in more developed countries. For example, Carlos Slim's company, Velcom, as Belarusian operator, earns less compared from each client compared to others, but in terms of its investment return, we we are in a very adequate, we demonstrate high efficiency. So these are aspects that are very understandable for us. So the issues of insurance medicine, it's not part of our mindset, mass mindset. If this practice should be followed, this would be a tectonic shift, change, a paradigm change with regard to the concepts or projects being discussed. Perhaps a decision has been taken on this scope, then the approach taken by the government. It's important to have a stage-like adequate pattern of implementation. We formulated for ourselves that we should have in place a global program designed for 5 years or maybe for a decade. Or are we dealing with just a group of projects, a series of projects with minuses and pluses, advantages and disadvantages? We don't think we can have both approaches. This eHealth system for Belarus that we are starting to develop, and there is a relevant question whether we can copy a system or we should go about creating something quite independent from others. We declared ourselves to be an e-country, so the users of this pool of expertise and competence is not our country, but the countries which are the recipients of the Belarusian products, EPAM, our EPAM, and other domestic companies like us. We could contribute to the development of such a system on a donation basis, so to say. I know that these companies have been taking part in relevant solutions for leading American companies. They create the most advanced projects there. So as for why I'm standing here, Welcome does not need to be introduced. However, a few words about us. We stopped being just a mobile operator in after the acquisition of Atlant Telecom. We became a convergent provider of telecommunication services. In May 2016, we launched a new area which is ranking at the same level with fixed and mobile solutions, and we are dealing more and more increasingly with ICT business, so that our economic operators and the economy at large gets solutions that dealing with infrastructure. First of all, from the cloud environment, Welcome has acquired technologies, assets, knowledge, competencies. We have a huge network across the country. We utilize more than $100 million for investment progress. We are ready to invest this money into projects that we're talking about. We take pride in the fact that we pass through annual audits with high standards. They are copied in Europe and in the United States, as we certify this Center for National Standards, international standards. We are comfortable in terms of creating systems of this. Then the question of operation of such a system is of importance. Yes, in setting up this system, we as providers of IT services, we can provide guarantees of continuous operation of such a solution. And we assert that we have all the technologies, resources, processes, and personnel and staff. I do not want to make it too much of it like advertising. We think that the cloud environment for this scale of projects is very relevant. I've talked about national standards, certification matters, the problem certification for such a cluster. Apart from requirement for intellectual capacity and a huge amount of work on the part of the operator, it will need to have attestation certification with the structure as a company that have passed through this kind of procedures together with colleagues from Big Cloud. We know how to do that. We could be we could deal with very serious blocks of this project, especially in what relates to security of information. Then a lesson from our practical experience when the Ericsson guy said that you have to buy hardware for such a project. We know for sure how it is done between the supplier of hardware and the user. The user requires certain functionality, and the vendor has to adjust. If I did not see that, they just increase the number of hardware 3 times so that they have a reserve to be sure about that. These are live cases. So the cloud, because of its elasticity and capability to add resources as soon as there arises a need and more demand, larger scale, so the cloud can deal with that. So cloud solutions are important because the consumer, the supplier of IT infrastructure and the consumer of these services, they have to come to enter commercial relations, and you can easily use it as a measure of efficiency. So this mechanism can become more clear-cut, more transparent. The quality of service provided can be improved. So the cloud technology show that all software, it is cloud native, it is adjusted for a cloud environment. It provides interoperability, and cloud technologies, as for in contrast to budget companies, adequately provides definition of terms and conditions, the scheme of payments as traffic isn't consumed, where the supplier of the cloud can ensure that irrespective of the traffic, the price will remain the same, and the cloud is serviced by specialized organizations, especially established for this purpose. So the matter or the issue of continuity, stability, support, this is also dealt with. This issue is dealt with. So otherwise, you can have all sorts of departures. So I've just outlined a number of advantages when we're talking about the issue of procurement. With this, I've wound up my remarks. Hopefully, it will be useful to you. If you have any questions, you're welcome.
Our next speaker will be about the strategy of electronic healthcare development in Belarus, and Mr. Vladimir Lapitsky, United Institute of Informatics Problems Deputy Director. Good afternoon, dear colleagues. Perhaps I should elaborate on the name. At Ministry of Health request, I was asked to talk about the strategy of e-health development in the country, showing and elaborating on the experience in this country on establishing e-health. So I'm afraid there are technical problems. I hope that the Minister in his presentation and other speakers have mentioned an important landmark in the development is the approval of the concept of e-health in Belarus till the year 2020. The key task, both in the concept of e-health development and overall goal, is the establishment of a uniform informational space for the entire public health. The key goal in implementing the concept and uniform space is the improvement of quality of medical assistance, better satisfaction of the people by public health, and of course improving the parameters and the outcomes of public health. That ambitious task should be implemented within 5 years, and in this case Belarus will be among 30 top countries with the best e-health systems. Those objectives which will be considered are presented on the slide. Out of them, I'd rather highlight the establishment of the national system of storing and processing of medical information, providing good access to it and the exchange of information, its computerized processing within the system of public health, and providing a broad range of medical services both for the population and medical staff. Ultimately, the development of the concept has involved the big number of people, including experts from different agencies and sectors, international experts. The group was established under the Ministry of Health, and they were developing the concept for 6 or 7 months. Prior to writing the concept, we have reviewed the international experience, and many has been said about that in the presentations. They reviewed Ericsson, for instance, experience, the experience in Kazakhstan, Croatia, Nortel company in Estonia and Lithuania, the experience of structuring the systems in Russian constituencies, as well as DLMC company, as well as other developers, including Philips. Ministry of Health experts visited the countries to see what has happened on the spot, and we have developed 2 trends. The public health can be built along the 2 lines. Firstly, establishment of the national system, or firstly, the regions should be piloted and that switch over would be to the national level. In Russia, they did almost the same. Firstly, they have regional systems of e-health, which are united and connected through service and services and national platforms with a national system. And let me go a little bit back. The key element in most of the countries is the integrated medical card or record. The Ministry of Health has pre-selected the approach of centralization through integrational approaches. Centralization of informational resources and services via the processes and putting together the resources which are available. This will be seen in the current status of informatization. And on this slide, I showed the main advantages of such an approach. This is first of all adding to already gained experience with its further development, planned implementation where there are the clear tasks for the upper and lower levels, the areas of responsibility, taking into consideration demand from different areas of public health. You know that we have different business processes, and it will be easier to adapt them when there are several players and suppliers from the lower levels. Many presenters have mentioned that monopoly should be excluded as well as risks mitigated. The concept states the conceptual transition to automatization from particular organizations to a common space. Here we present the key tasks we'll be considering. First of all, uniform standards, regulations and specifications. Unfortunately, if comparing CIS countries, Belarus is lagging behind in the process. Currently in medical informatics, there are no standards at all. Moreover, it will result, and Ericsson has mentioned that, changing regulatory documents. Much work has already been done. The list of standards anticipated for passing has already been drafted, as well as the regulatory documents which should be introduced, whether written or adapted, and some proposals have already found themselves in the Ministry of Health. Conventionally, they call them localization of the processes in public health. All the presenters were mentioning integrational platforms in the system of public health, providing establishment of the national content of medical information in order to provide good interaction with all the stakeholders, providing broad range of services. Again, better protection of personal data, public health information, as well as establishing a uniform database about the patient and providing the broad range of services. Drivers for the concepts are well known to you. That will be the financial support through the World Bank project, which is called Modernization of Public Health in Belarus. The first component there will be the development of the system of eHealth in Belarus and establishing the systems of clinical decisions passing. This project was launched last year, and we hope that its implementation, according to the Ministry of Health, by 75% will provide implementing the concept of eHealth till the year 2020. And let me also say, perhaps my slide will be repeating themselves, or you have seen the information before. Here you see the operators from different services working at the market. Currently, the analysis annually carried out by the Ministry of Health shows that Belarus has well-developed local informatization. Here you see the percentage. The most advanced is Minsk, of course. There the process is almost over. Grodno Oblast should be complemented, Pinsk region in particular, and some other. Presently, we have got some national system like registers and the national system on particular types of accumulating information. Some slides will follow. There has been intensive development of the corporate network. Minsk has already been covered, and now intensively has been introduced the system for the region. And e-prescription is the key document. Now we have two providers for corporate network, Bell Telecom and Delovaya Set, business network. And here you see in bullet points the resources at the national scale. We have a number of registers for diabetes, for cancer, TB register. There is a national system on accounting injuries, disabilities. And now intensive telemedical system is being introduced, staffing, and very intensively e-prescription system has been introduced. The foundation for local informatization will be the establishment of the intelligent-based public health system. I will be giving comments what one may expect or which requirements will be imposed within the concept and the World Bank project. Firstly, overall automatization of treatment diagnostic processes and those processes accompanying them. Another important requirement, especially based on WHO recommendations, is complete digital integration between the diagnostics and equipment, including treatment equipment and the laboratory equipment. Use of web technologies and the technology of thin or delicate client, and it applies to management of all databases and also rendering a number of services for the population. In this country, we have got very good developers offering comprehensive package decisions for the tasks of hospitals and outpatient clinics. There are good examples from different regions, from Minsk, Grodno, Brest, where you can see well-advanced developments which cover almost comprehensively treatment processes, including integration of the equipment, including barcode technologies and some other systems. Outpatient clinic systems for the hospitals, for inpatient facilities as well. Currently, we have got a number of e-services. You are aware of them: internet booking, calling the doctor at home, self-booking, and now we have the e-line integrated into the medical information system. E-prescriptions and identification plastic cards may be seen as temporary decisions, but anyway, they have been functioning. And plastic cards provide quick and convenient access. There is an internet portal which you see on registration in Belarus, which is called Talon Buy, Ticket Buy. So the number of people involved is immense, and the frequency of visits is quite good. And here you see the e-registration terminals of self-booking. They have been intensively used in outpatient clinics all around the country. The booking can be through internet, and it gives a good relief to human resources in outpatient clinics. Here you have some figures quoted. Up to so that is after 15% it goes much bigger. E-lines are interconnected in order to decide on the allowances and benefits for particular patients. In Minsk, they have been using mobile solutions for supporting calling up the doctor to patients' domicile. There are the cards for the physical placement of the patients. One can get e-prescription or get the assignment for laboratory diagnostics straight from home. There are many more opportunities, including the protocols. Let me also say that not only in Minsk, but in other regions, there is good regional interaction between public health institutions. And I'm talking about the current status. We would love to see the acceleration. Corporate network has been developed all around the country, and particularly in Minsk. 300 institutions all around the country have already been connected to such a network. There is a single entry point. In Minsk, for instance, most intensively, the system has been used, which are input to it. There are different telemedical systems on X-raying, on mammography, and they are the elements of rendering health assistance. They are the elements of rendering medical assistance, and telemed is an important part of it. The committee has assessed the efficiency of it. From 1 million to 2 million euros will be the savings. As to X-raying, in the database there is information about 1 million citizens. Remote access is provided. People can review their status. 15% are the images which are considered as normal. Previously, the people were assigned to different institutions, TB, oncological, but after the introduction of the system, the reduction of unnecessary reassignments has been reduced by this figure. Such a system has been used in Minsk, Brest, Oblast. The similar system is about digital mammography. Much experience has been earned, and many of you have mentioned on introduction of Yeris in Moscow. Philips is one of the leaders there. E-prescriptions has been intensively used, and that was mentioned by Ericsson. Start the process from the pilots, and e-prescription was the case from the pilot prescription project. Uniform for Minsk service of pathological anatomic services using barcodes, and the feedback is also sent in the e-form and immediately put into the e-record of the patient or into the history of the disease. Laboratory services have already been covered. Central laboratories are covered, and a number of other services. Ambulance is involved, prompt access to calling upon ambulance. You know that there are special teams. Screening of mammal gland cancer and some other services. And let me go back to what is being planned or assumed while implementing the concept of eHealth in Belarus and the project of the World Bank. Previously, I was showing you that local informatization is well developed, and this year we've seen a mission from the WHO as well as from the World Bank, and the appreciations of development was quite high, and they can be even comparable with the West European standards and peers. Which principles have been used? The key principle is centralized system of public health. It has been mentioned many times. The use of technologies of cloud computations or the use of software with open code, very important service-oriented architecture which will be helpful in future in developing the system of eHealth in the form of PPPs. The architecture is indeed important. Welcome has mentioned that the rules should be clear for all the stakeholders and players from the top to the bottom. Technologies, web technologies, there should be scaling systems, simplicity of interfacing, interaction with and interoperability with other systems, interaction with the other public informational system, first of all, security of information. And here you see the simplified scheme. So it's quite similar to those presented by the others when sharing their experiences. But anyway, and conventionally that is called a two-tier system. Support to the organizations in public health. In the concepts, as I said, 50% within 3 years of informational resources with local placement should be stored on cloud. At least as of today, the trend is such that all regions with a population fewer than 30,000 should be relocated for storing and functioning through the cloud processing center. According to EDIC 34, it will be the national platform. Big Cloud will be involved. Welcome states that they have the cloud center. And perhaps the Ministry of Health will have a number of partners providing placement of the informational resources. Some informational systems of local scale will maintain, and they will be in compliance with safety regulations. So there will be a physical placement in the organizations, but at the stage of their upgrading, as anticipated, they will further be functioning through clouds. And most important is to establish the centralized platform that will provide accumulation and concentration of information for e-services. The key element will be electronic health card or record, providing accumulation of all the information, which will provide furnishing of the service and further transplanting into the registers for business analytics, and in future they could be used for big data technologies. There is the number of supporting service routers, the uniform system of identification of electronic signature. Very important element will be the interaction with the national informational system, which is currently is being developed within the system of electronic economy. The concept was approved by the government, especially as to interaction with e-government system being established in this country. There will be some services to other agencies, and as stated, within the portal of services, there will be the personal cabinet of the patient, and some opportunities are even stipulated right now. One should understand that there is experience by local developers. This year, the Ministry of Health decides to have the audit of all domestic developers as to compliance with the requirements, centralized platform, the requirements on functionality or web technologies, distribution of software and so on. There is the way forward, but a recommendation pool of the developers might be further used when integrating into the centralized platform. So what will happen next? Currently, within the World Bank project, 4 key tasks are being considered. They are standards. Amendment of the documents for eHealth and 2 big lots, that is the integrator of the platform with a commitment of integration of all the systems which will maintain in the organizations in public health, and the next lot will be system integrator or the lowest level, providing the development of local computing networks with the budgets, estimating the costs on computing equipment, expansion and upgrading of current medical systems, their capacities, or supplying new technologies or cloud technologies. The tasks on informational security and integration with the central platform. They are key global tasks being considered by the World Bank projects in order to implement the concept of eHealth. Scaling of the tasks, I've told you that there will be the lowest level. Some of the resources will be maintained at local placement. There are good centers under the Ministry of Health, for instance, in clinic number 5 or hospital number 9 in Minsk. Mainly the population, so that is the storage will be for 25,000-30,000. Here are the opportunities of the centralized platform are shown. The following capacities will include EHR for patients, also monitoring the circulation of information within the country, the service of e-recording, calling up the doctor, personal cabinets. Another stage is supporting passing of clinical decisions. That will be the lot within the World Bank project. At least the strategy will be introduced, saying that at the first stage the system will include maintaining of clinical protocol and also drugs susceptibility when prescribing modes of treatment. Integration of the system with the national system and Belarusian payment settlement system. In the morning, we've heard the presentation by the Minister of Health for what MC will mean, its use as the basic element of eHealth. It will be repeated. Personal cabinet will be implemented. Some of the functions have already been introduced, such as calling up the doctor, the access to e-prescriptions for chronic diseases, prolongation of the e-prescription without visiting the doctor. There will be some regulatory endorsing documents by Ministry of Health, access to the leaves, to the sick leaves, the feedback with the organizations such as notifications for dispensarizations and the other opportunities. Also access to medical information, including maintaining your own medical card, your fever, your appetite, and using the devices of mobile health, measuring the contents of sugar in your blood, and so on. Within the project, there will be good services for interagency interactions. They are presented on the slide. Birth certificate or death certificate, health status statement. When you are getting your driving license, for instance, you can get all the information through e-channels, and they are the services which will be implemented by 2020. So the task is to move from the current level of informatization towards grade number 5 of maturity. It has been mentioned that it will be comprehensive interaction between the doctors and patients. And we hope that will achieve the goal, but most important is to have the proactive position both from the ministry and doctors. Another important incentive might be proactive civil position of the patients. They should use electronic services and even demand from the public health system the introduction. And thank you for your attention. Thank you very much.
Dear colleagues, we've finished the first day of the work of the conference. I'd like to thank all the speakers for their good, adequate preparation and for the high quality of their remarks. Those in the audience were able to get a share of important aspects of their remarks. They tried hard to show the crust of the matter in different aspects of an e-health system in particular countries. We have tried to show you the main points built into the concept of the implementation of an e-health system in the Republic of Belarus. Hopefully tomorrow during the roundtable and in panel meetings you'll be able to share your views on the concept of an e-health system in Belarus, which will make it possible for us to move further along this road. Hopefully tomorrow at 10 we'll meet in accordance with the agenda approved for this second day. Now you have an opportunity to comment. You can also send your comment to the website and to the website of the Ministry of Health. We will thoroughly examine your comments and will take them into account as we implement the e-health system. So once again, do you have any questions or commentaries? Then till tomorrow. Tomorrow we'll then deal with your opinions, commentaries,